Hi, thanks for tuning in to this introductory lecture about post-traumatic stress disorder, PTSD. I'm Ashley, and today I'm just going to be walking through a few of the basics about what PTSD is. So really broadly, PTSD is a psychiatric disorder that characterizes someone who has difficulty recovering after having experiencing a terrifying or traumatic event. And when we're thinking about PTSD, we're really talking about very specific types of situations that involve exposure to actual or threatened death, serious injury, or sexual violence. And this could be something that is directly experienced. It could involve witnessing in person the event as it occurred to someone else or other people. So seeing something that's terrifying on television, for instance, or on the news doesn't qualify as trauma. Learning that the traumatic event happened to a close family member or friend, particularly when that event was violent or accidental. And then finally, having repeated or extreme exposure to aversive details of traumatic events. So this typically involves first responders, police officers, for instance, who might be privy to a lot of details about child abuse, paramedics who maybe see a lot of graphic injuries or violence, things like that. So despite this kind of specific definition of what a trauma is when we're talking about PTSD, there are lots of different types of events that qualify as trauma. So this could be something from a motor vehicle accident, natural disasters like floods, hurricanes, earthquakes, combat, assaults, just accidents and injuries. And one thing to note is that up to 90% of people will experience at least one traumatic event in their lifetime. However, it is important to note that most people who experience trauma don't go on to develop PTSD. And PTSD is diagnosed according to criteria set out in the DSM-5, which is kind of our manual for mental health disorders. And an important note is that PTSD is a highly heterogeneous disorder, which just means that there are lots of different ways to have PTSD. So one person with PTSD might look very different from someone else with PTSD. There are kind of some specific features that characterize PTSD, which I'll go over in a minute, but the combination of symptoms can be very different from one person to the next. And in fact, there are actually over 600,000 different ways to have PTSD to meet criteria according to the DSM. And so PTSD is largely characterized by these 4 symptom clusters that capture symptoms related to intrusive re-experiencing, so having unwanted memories of the trauma, avoidance, changes in cognitions and mood, as well as symptoms of kind of hyperarousal and reactivity. So these numbers that you see on the left kind of hint at how different PTSD can look from one person to the next, because you need one symptom from cluster B, that intrusive re-experiencing. You need at least 2 of some of these other symptom categories. So you don't necessarily have to have all of the symptoms, but you do kind of need to meet this mathematical equation. And so the specific symptoms kind of within these clusters, so when we're talking about re-experiencing symptoms, those are really capturing kind of being bothered by unwanted memories, maybe nightmares, having flashbacks, just being very distressed when things remind you of the trauma. So whether that's, seeing something on TV or in the real world, things like that. Whereas avoidance is capturing ways people are going out of their way to avoid remembering or thinking about the trauma, or avoiding external reminders of the trauma. So this could be particular people, places, activities, objects, situations. So for instance, you might have someone who was in a bad car accident start to avoid the intersection where they got in the accident. The negative thoughts and mood cluster has to deal with kind of changes in thinking and emotion that come about after the trauma. So oftentimes people who have PTSD have really persistent and exaggerated negative beliefs about maybe themselves, other people, or the world. So these kind of just global thoughts that I'm a bad person, or no one can be trusted, the world is a dangerous place. Just kind of this representing this shift in how people are seeing themselves in this kind of overly negative way. Another symptom could be distorted blame, so feeling really guilty, blaming yourself or blaming someone else, even when other people are maybe disagreeing. So for instance, if someone is assaulted late in the evening, they might blame themselves because they feel guilty that they were out that late in the first place. Other symptoms in this cluster include kind of a loss of interest or pleasure. So that's what we call anhedonia, so just being less interested in things that they used to enjoy. Having persistent negative emotions just generally, so feeling really afraid or sad, angry, guilty, ashamed all of the time, and feeling kind of emotionally cut off from other people, so more socially estranged. And then finally, the hyperarousal cluster has to deal with this just kind of like increased state of reactivity. So you might see this coming out in people with PTSD just being more irritable, whether that's kind of more likely to snap at someone verbally or maybe throwing things. This hypervigilance, feeling really on guard or watchful a lot of the time, even when there's no particular threat or danger. Being especially jumpy, having problems with concentration, difficulty focusing, or also having sleep disturbance. So not just having nightmares necessarily, but also maybe having trouble falling asleep, waking up way too early in the morning, waking up throughout the night, things like that. And then finally, this is kind of how we categorize a lot of mental health disorders in the first place, where it's important that the symptoms themselves are actually interfering with someone's life. So whether they are having a lot of distress, they're just really bothered by having these experiences, or it's actually functionally getting in the way of their life in some way. So, it's maybe kind of having some negative effects on their relationships with other people. Maybe it's getting in the way of them doing a good job, or even going to work or school, or just any kind of area of their life. And then it's also important that it's not due to the physiological effects of a substance or some other medical condition. And with PTSD, it's important to note that we also have this kind of important symptom criteria that the symptoms have to last more than 1 month. And I'll talk about a little more about why that is in just a second. But there are a couple of other specifications that I just wanted to briefly point out, where there's a dissociative subtype of PTSD, where people, in addition to these kind of core symptoms of PTSD, also have these experiences where they maybe feel like the world around them isn't real, like they're in a dream or a movie, and this just kind of dissociative experience is what we call that. As well as individuals who have delayed expression of PTSD. And this is kind of its own subtype, because most people with PTSD start to exhibit symptoms pretty much immediately after being exposed to trauma. But in there is this kind of minority of trauma survivors who are resilient in the immediate aftermath of trauma, but then later go on to develop more severe symptoms of PTSD. So this delayed expression characterizes PTSD that isn't met until at least 6 months after the actual exposure to trauma. And so, like I mentioned earlier, most people, despite being exposed to trauma at some point in their life, do not develop PTSD. So it's very common for people to experience symptoms of PTSD kind of immediately after the trauma exposure. That's kind of a normal part of the human experience, to be very upset, to have some of these symptoms in the days to weeks after something terrifying and maybe life-threatening happened to you. But only about 6 to 10% of trauma survivors develop chronic symptoms of PTSD, which is often characterized as symptoms that last at least 3 months, though only 1 month is necessary for an actual official diagnosis. And so trauma recovery kind of looks like this. So that PTE that you see on the graph is where trauma exposure actually happens, so a potentially traumatic event. And you can see there are kind of these different recovery trajectories that are pretty commonly replicated. So you have folks who are resilient and really just never have significant symptoms of PTSD. You have folks who have chronic PTSD, where immediately after the trauma they're highly distressed, and that just doesn't get better over time without intervention. You have folks who, which is typically the majority of people, who are highly distressed immediately after the trauma, but then recover over time without any particular intervention. And then finally, that delayed trajectory that I just kind of mentioned on the last slide, where symptoms don't really start to interfere until several months after the trauma. So when we think about who's at risk for PTSD, there are some known risk factors. So one of the prominent risk factors is being exposed to an intentional and interpersonal traumatic injury. So these are physical assault survivors, sexual assault survivors. We know that certain types of trauma are related to increased risk for PTSD. Women are also almost twice as likely to be diagnosed with PTSD as men. A history of childhood trauma increases risk for PTSD. And then having a personal or family history of mental illness also increases risk. But there's also really ongoing work that's trying to better understand resilience and what are protective factors against PTSD after trauma. And so a couple of the kind of more well-known ones include social support. So having a strong network, whether that's family, friends, just other people who can be relied upon for support after exposure to trauma, is really protective against PTSD. Also having greater cognitive flexibility, so being able to kind of think flexibly about what happened to them and how that relates to their life and what's the meaning of this event in the grand scheme of things. And in other good news, we have many scientifically supported treatments for PTSD, and this includes both psychotherapy and medication options. So when we're thinking about psychotherapy, most of the empirically based or scientifically supported treatments are cognitive behavioral therapies that are designed to target thoughts and behaviors and kind of their intersection with emotions. So one therapy, prolonged exposure therapy, is often considered the gold standard psychotherapy for PTSD. And in prolonged exposure, PTSD patients are taught to gradually approach distressing trauma-related memories, feelings, and situations through exposure. So basically facing their fears. And this is done both through imaginal exposure, where patients are asked to kind of keep going over and over and over and telling their story of what happened until it becomes less distressing, as well as learning to face things that they may be avoiding in their real everyday lives. So in vivo. So this could be things like avoiding driving or avoiding particular places or avoiding watching movies that are depicting war scenes or things like that, depending on the actual external reminders that people are finding distressing. And there are a couple of kind of similar iterations of exposure therapy. So you have written exposure therapy, where instead of where folks are actually writing their story instead of saying it out loud, as well as EMDR, eye movement desensitization and reprocessing therapy, which is somewhat controversial, but does have some empirical support, mainly because it includes this component of exposure. Cognitive processing therapy, or CPT, is another more cognitive or thought-based therapy, which helps people learn how to modify and challenge unhelpful beliefs related to the trauma. So for instance, if someone is, has a lot of depressive symptoms after the trauma, and is maybe spending a lot of time blaming themselves for what happened, CPT can really help target what is the basis for these thoughts and how are they tied into how you're feeling, and are there other ways of thinking about it. And then medication options often include selective serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors, SSRIs and SNRIs, which are also commonly used for depression. All right, so hopefully now after this introductory lecture, you've got a good sense of what PTSD is, and you can recognize some of the common PTSD myths. So myth number 1, PTSD only affects soldiers. This is not true, even though we often are exposed to information about PTSD in veterans. PTSD can occur after any event that involves actual threat or threatened death, serious injury, or sexual violence. And PTSD happens to be most prevalent in traumas that involve interpersonal violence or combat. Second myth, PTSD is inevitable after trauma. This is also false. Most people will be exposed to trauma in their lifetime, but only 6 to 10% of people will develop PTSD. And while PTSD symptoms are common right after trauma, they typically resolve without any specific intervention for most people. Myth number 3, PTSD isn't treatable. This is also false. Many treatments for PTSD exist and are backed by science, and these include both psychotherapy and medication options. And finally, all people with PTSD look the same. As we discussed earlier, there are a lot of different symptoms that can be involved in PTSD. It's a highly heterogeneous disorder, and there are over 600,000 possible symptom combinations that people could have to meet criteria for PTSD. So that's it for this introductory lecture. In future parts of this module, we'll be going a little bit more over some of the neurobiological features related to PTSD, now that you have a sense of what it is. Thanks for tuning in.